We will start with EUS instrumentation, and the purpose of this talk is to make you aware of the devices that we use during endoscopic ultrasound. So this is what the linear endoscopic ultrasound scope looks like, and just to make it clear, right now, as EUS has evolved, radial EUS is usually not done, or I would say not required. In majority of the cases, I would say you can do majority of the procedures with linear EUS. And therefore, I think for the last many years, except for some occasional cases, we have not been using radial EUS. Whatever the importance was of radial EUS, if you do a meticulous linear EUS, you can look at all those lesions without any difficulty. Moreover, the major advantage of linear EUS is that it can do a therapeutic procedure, which radial EUS is unable to perform. So things you need to know about EUS: it's expensive, it lacks versatility, and it's fragile. The reason why I mentioned this, because you have to handle this instrument carefully, because the cost of the repair procedure is very high, and if you have got only one EUS scope in place, then it becomes a real problem. And there are importantly three manufacturers. These are Pentax, Olympus, and Fujinon. And in broader sense, most of these scopes by these different manufacturers are comparable. So radial EUS, it does imaging at 360-degree. So what does that mean? It is similar to that of a CT scan. So this is what the axis of the imaging of a radial EUS is. While in linear EUS, the image is parallel to the axis of the scope. The difference that it makes is that you don't see the whole structure in total in a single view. So you have to rotate your scope clockwise or anti-clockwise to complete the evaluation of that particular structure. So that's very, very important. So radial EUS scope, as I mentioned, we don't use it, but you should know what are the important features. As I mentioned, 360-degree field of view, frequency ranges from 5 to 10 megahertz. Small X-ray channel 2.2, with which you can do a mucosal biopsy. There are three major players, as I mentioned: Olympus, Pentax, and Fujinon, and there are some differences in these scopes in radial as well. Olympus is an oblique viewing, while Pentax and Fujinon are forward viewing. So you may encounter some difficulty while insertion of the scope. However, when you do an EUS imaging, it doesn't matter. Pentax forward viewing, inability to fully retroflex, that is one of the issue. Fujinon, again, forward viewing, slimmest. So this is the thinnest of all the scopes that you have, and most endoscopically flexible. So having said that, it doesn't mean that one should go for a Fujinon alone. This just tells you one of the important differentiation in the handling of the scope. However, when you image a lesion on EUS, it doesn't help you in that aspect. So what I mean when I say the frequency ranges from 5 to 10, if you see the bubble wall, so lesser the frequency, lesser is the resolution. If you have higher frequency, the depth of the evaluation decreases. However, the resolution of the particular lesion improves. So if you want to image a structure very deep and you use a high frequency, it's not going to solve the purpose. So when you have a lesion, which is say in the wall, where you want a better resolution, then you can use a higher frequency to evaluate the lesion. So this again, Pentax, Fujinon, Olympus, channel size 3.8 Pentax, 3.8 Fujinon, 3.7 Olympus. So whether that really translates into some difficulty, yes, it does. If you want to push in a 10 French scope, a 10 French stent, you may have a tough time with the Olympus compared to a Pentax or a Fujinon. Again, the scanning plane is 120, 124, and 180. That is maximum with Olympus. So what does this scanning plane mean? So scanning plane primarily is the whole angle along which you are imaging that particular lesion. Does that make a difference? Yes, it does. When you are seeing at a particular area, you have more area of visualization on the EUS image. That's what the difference with a scanning plane is, which is maximum with Olympus, and Pentax and Fujinon almost similar. So this chart just tells you the frequency with Olympus ranges from 5 to 10. Then with Pentax, it again is from 5 to 10. This is, and with Fujinon, it goes up to 12. So you have a maximum frequency of 12 available with Fujinon. Does that make a difference? Yes, it does, because you are better able to get a resolution when you are imaging a particular lesion. What is field of view? So when you pass an endoscope, say an upper GI scope, the area that you can see is the field of view. So there is a difference between a field of view and a scanning angle. Scanning angle is related to the angle of visualization of an EUS image. It has got nothing to do with an endoscopic image. So endoscopic field of view, if you see of majority of the upper GI scopes or colonoscope, is around 100 degree, and this is what you have with Olympus EUS scope. This is 100 degrees. With Pentax, slightly better. So how does it make a difference? Yeah, when you are passing a scope without just by endoscopic image, you have a better area of visualization. So that's what field of view is. And Fujinon, that has got maximum, that is 140 degree. So this is not going to translate into an endoscopic EUS image benefit. So it's not an EUS image benefit, it's an image benefit of the endoscopic image when you are passing the scope. That's what it is. And as I mentioned, scanning angle, I have already told you. So comparing the diameter of the scope, this again is very important. I have mentioned that earlier. 12.6 with Olympus, channel is 3.7. Pentax, it is 12.8, channel is 3.8. Again, Fujinon, thickest scope, 13.9, and channel of 3.8. So this is what the difference is. A brief words about this is one of the scope available with Pentax. This is a slim scope, and the advantage is primarily thinner diameter. So the diameter this may help you in doing EUS in child. So recently, I think we did EUS in I think 3-4 year child looking for a duplication cyst, and we preferred to use a slim scope. The reason I preferred was that while passing the scope through the pylorus, the thick scope, the bigger one, the normal one, I was a bit scared that we may not perforate the duodenum. So again, not too many uses, but in children, obviously, this may be beneficial. So it has got 2.8 millimeter instrument channel, insertion tube is 10.8. Again, FDA, use FDA approved. So this is again important to know about forward viewing scope. So what's the advantage of forward viewing scope? So as you all know, these scopes, the linear scope that we use is an oblique viewing scope. So it's an oblique viewing. However, when you have a forward viewing scope, this helps in therapeutic procedures. So your field of view becomes better when you are using a forward viewing scope, though we don't have the scope, but commercially available. And primarily for interventional procedure, short distal tip, straight working channel, you can do an extensive angulation, which helps you in therapy. So this is being used for long in Japan. So processes, again, there are certain features which each company claims about the processes that they have used. I have put this, may not be essential to remember. This is super small, super CCD chip, which is available. THI, tissue harmonic imaging. So this I have mentioned in EUS processors by Fuji, but this is now available with Olympus as well as Pentax. So tissue harmonic imaging, this is a term which you need to know. And what does this mean? The tissue harmonic is primarily is It's again, you are playing with the harmonics or the waves that are generated in the ultrasound imaging. And it's a novel ultrasound acquisition method that provides better ultrasound images by using second harmonic signals. This is what the principle of THI is. And what is the advantage? You have improved lateral resolution, reduced side lobe artifacts, and increased signal to noise ratio. So what this ultimately means, so if you see this first image and see the second image, so what you have, the resolution of this lesion is better visualized. It is just a press of a button. You switch on the button and you have a THI imaging. There is another thing known as compound imaging, and purpose of all these modalities is primarily to make your image better. For THI, it is primarily improved lateral resolution, reduced side lobe artifacts, and increased signal to noise ratio. This is what THI is. Again, the reason I have put this up, this Noblus, I have used this in other center. This is a small machine, so portable machine. You can obviously move in and out nicely, easily. So if you want to do a procedure, say in ICU, maybe you want to do an EUS guided pseudocystic drainage, this is bit easy to transport. So that's what advantage of this Noblus is. Otherwise, the features remain the same. And as I mentioned, the compound imaging, the advantage is enhanced organ boundary visualization and reduced angle dependent artifacts. So I would like to tell you this compound imaging and THR is now available with almost all the three major companies that you have. Coming to Olympus, what we have is EU ME2 right now, and the latest that is available is EU ME3, now installed in 2 or 3 centers. We don't have it right now. So imaging frequency, as I mentioned, is ProSound, that is Aloka 1 is up to 10 and up to 12 megahertz with ME2 now. One of the features that they have added is E-flow feature. And what is it? This is increased sensitivity to flow at low velocities and in small vessels, helpful for ideal path of needle puncture. To me, this is one of the very important techniques if it really makes a difference. So why? Because when you're puncturing or doing an FNA or an FNB, one of the major concerns that you have is bleed. And if you are able to detect small vessels with some imaging feature, that really makes a difference. You can apply Doppler, which you obviously do before you puncture, and you know that there is a vessel around. You need not go through the vessel or choose a separate path. So this is what the machine looks like. This ME2 we have with us. A word about elastography is again one of the important features of endoscopic ultrasound, important image modality. And the elastography, again, we use it off and on, not on a regular basis, but it really impacts when it's really required. So what is it? It's a method for real-time evaluation of tissue stiffness. So with elastography, primarily you have to understand that we are just detecting the hardness of tissue and nothing else. So a chronic pancreatitis gland, pancreas, because of chronic pancreatitis can be hard, and it can be as hard as CA pancreas. Because of autoimmune pancreatitis, also pancreas can be hard. However, if we have a soft pancreas, it will be green. So I'll just come to the color coding. But what you have to understand primarily is what we are doing is trying to pick up the hardness of tissue by elastography. This is what you're doing and nothing more than that. So malignant tumors are usually stiffer than benign masses. Usually, elastography is characterization for benign and malignant tissues. All these processes have elastographic capabilities now available with almost all. So this is what it looks like. So if you have a soft tissue, this will be either yellow, then green, and very hard tissue is blue in color. So you are trying to introduce deformation by applying transducer and sometimes by the respiratory movements that is there already. And this is what you are detecting with elastography. So hard lesions, blue, soft lesions, red, intermediate ones, green. So then one of another features that you have is a mini probe. Again, I would tell you that this we are not using, but may have a role to play in certain areas, and it's always important to know these things. So for small superficial lesions less than 1 centimeters in the esophagus, stomach, or the biliary system, you have this mini probes. It's available only by Olympus. The size is 1.4 to 2.6 millimeter and long enough to reach the duodenum. It's a mechanical radial one, 360-degree field of view, high frequency. So that's the difference. So you are able to get a better resolution. As I mentioned, as the frequency increases, the resolution of the wall layers of the structure near to the probe improves. So this is what it does. So if you see, the frequency is up to 30 megahertz, so very high frequency. So if you want to see a structure which is very nearby, you place a probe just near to it, you have a very good resolution of this. Again, needs a motor-driven unit. So one of the problems with mini probes is that it does not have a biopsy capability. So that is a problem. It does not have a channel for a biopsy, and it is advanced to the working channel of the scope. A balloon sheet may be used to enhance acoustic coupling, and this is how it looks like. This I'll just show you. So the problem is again mini probes may be costly, and one mini probe you may be able to use for around 50 to 100 procedure. This is how it should be stored. And once you are passing the mini probe, you should know that it should transduce. It rotates actually. It should not be rotating in pass, and elevator should never be touched when a probe is in place. The reason why I mentioned this line is this is again costly. You will lose the mini probe straight away if you don't follow this. That is, unless it reaches the particular site where you want to image, you should not be using the elevator to with the mini probe. Otherwise, you will damage the mini probe. This is how it looks like. So this is what the mini probe is. It comes out through the channel of the scope, and this is the motor driving unit of the mini probe, which is needed in addition to the processor that you already have. So now FNA needles, I think this is again very, very important because this obviously you will be using all the time when you are doing an EUS. So different needles have differences in needle tip, stillet composition, differing sheet material, length, and unique handle design and feel. So proprietary modifications in needle can be laser etching, mechanical dimpling, or sandblasting of the tip to enhance ecogenicity. So these are the different things that different manufacturer does to make their needles better. So this is what they're doing. The material that is being used for needles can be aluminum, stainless steel, chromium, cobalt, and nitinol. So this is what you need to know. Why this is important, I'll just come to that. So if you see this, these are needles from different companies by Cook, Boston, Olympus. So what we use here in our center is predominantly Boston needles. So if you see this Cook needle, it is coiled sheet which facilitates greater needle flexibility. Then you have the Boston needle. So Boston needle is made up of cobalt chromium. This is an alloy. So cobalt chromium, it provides benefit over stainless steel alloys, including greater hardness and tensile properties to deliver superior needle penetration. So what does it mean? So when you are using a cobalt chromium construction of the needle, then the needle is harder and you have a better puncture of the penetration of the needle. So that's what the advantage of the chromium cobalt construction is. Again, Olympus uses the typical manganese tip, which allows for smooth puncture even for oblique angles. So very sharp tip, And I think this is one of the advantages of Olympus Easy Shot 3 needle, because the manganese chip, this allows for better penetration. So this is how the different needles look like. A word about these are FNA needles. A word about the FNB needles. So before I go into this, these are the different FNB needles. So the difference between an FNA and an FNB needle is primarily the tip. The only difference is the tip. With FNA, you are acquiring cells predominantly, while with FNB, with the biopsy, you get tissue, you get core. So I think once we do today, we'll be doing both FNA as well as FNB. You will see when we get the material with the FNB, we get tissue, we get core. So we get the whole architecture of the tissue. That's what the difference is. And these needles predominantly, there is a difference in the tip. That's the only difference. So you have a sharp core needle, you have an acquired needle, which you will see today. We have this needle, we are using this needle on a regular basis. This is known as Francine tip needle. This is the needle which was initially available, the first needle to come as a biopsy needle. This is Pro Core, which has got a reverse bevel. So this is what the bevel is, and this is the reverse bevel this is by Pro Core needle. So if you see these needles, Cook needle, again, core trap technology designed for receiving sample into the needle. Boston needle, this one needle I showed you. These you can see these cutting surfaces, 3 important cutting surfaces. This is what I mentioned. 3 symmetrical cutting surfaces with fully formed needles are designed to maximize tissue capture and minimize fragmentation. So all these designs are predominantly meant to have a bigger chunk of tissue. This is what you are doing. So initially, I remember we got this Francine needle way back, maybe around 6 to 7 years back. So when we are doing FNA, obviously, sometimes you will find that you don't get adequate material. So if you are using these needles, biopsy needles, so I think we have a separate talk on biopsy needles, so we'll discuss that in detail. So the advantage here is because of that particular shade that you have, you are able to get better tissue here. So sharp core has got 6 distal cutting edges. So these are 6 distal cutting edges. If you count this will be 6. This is by Medtronic. And again, you need to know about celiac plexus neurolysis needle. We have been using this needle for celiac plexus neurolysis, though this celiac plexus neurolysis can be done with a normal 19 gauge FNA needle. So how this is different? This is a cone-shaped needle tip with side holes. So there are side holes on the tip, and what these side holes predominantly do is to deliver the alcohol that you are injecting in a complete fashion. So if you just have opening at the end, so I'll just play this animation video. So if you see this of an FNA, celiac plexus neurolysis, this is what the celiac plexus look like. You pass the scope, you puncture, you look for the celiac artery and inject at the level of the celiac artery where the celiac ganglion is located. And so you have the injected in the form of a shower. You can see this. So this is what the advantage of a celiac plexus neurolysis needle is. Though there aren't studies to prove that this is better than an FNA needle, but we usually use this to me makes more sense because you have adequate distribution of the injected in the area where you are injecting. Again, More microforceps, we have used this in few patients. Unfortunately, we have not been able to get adequate material with this, though there are studies which suggest that this provides you good material. So just a word about what it does. It has got serrated jaws, as we can see, and this whole assembly passes through the 19 gauge FNA needle. So what you do is normally we use this for taking biopsy from a cystic tumor. So this is from the wall. So you puncture with a 19 gauge FNA needle, take out the stellate, and then pass this More biopsy forceps inside the cystic lesion, go to the wall, and with this serrated jaws, you are able to get the material that you want. So this is what the purpose of More biopsy forceps is. And then just a word about needle-based. So what I'm telling you is all the devices which are being used in relationship to EUS, about which you should be knowing. You may not be using all, but you should be knowing at least. So this is confocal laser endomicroscopy probe. This can either be a probe-based technology or a needle-based. So with EUS FNA needle, you use a needle-based confocal laser endomicroscopy probe. So basically, what you have is the resolution of the image, as you can see, 10,000 fold times. So you can puncture with a 19 gauge needle, pass the CLE probe, that is needle-based probe, and then you are able to get an in vivo histology. This is what it does. So this is obviously this is an expensive SGPGIMS device which you need to have if you want to use this confocal laser endomicroscopy probe. This is what the probe is, which will go through the 19 gauge FNA needle. These are the images, what you get. So primarily what you are doing is to compete with the pathologist having a real in vivo histology in place. So this is what the advantage of confocal laser endomicroscopy is. So I think I just want to show you about this EUS RFA probe. Again, I haven't used this, but we'll get this very soon. So it can be passed again through 22 or 19 gauge FNA needle. It is RFA probe, 1 French in diameter, monopolar wire with a 20 millimeter segment at the tip of the wire where current is conducted. So just to give you a feel how it looks like, I have taken this video from the company's website. So if you see this, these are the devices that are there in the EUS RFA probe. I think this is now commonly being done in many centers. Not a difficult technique to do, but to understand. So you can see the tip part is the active part, which will bring about the ablation or the coagulation of the tissue that you need. And if you see, this is the whole device that is available. This is similar to your FNA needle. This is the part which is RFA active part. This is the insulated part to prevent further damage to the tissue. And this is again sheath that we have. So again, I think it's difficult to understand all these things based on just video if you haven't used it. But the reason I put it is you should be knowing that you have an RFA, EUS RFA available primarily for pancreatic neuroendocrine tumors. Usually the studies are on insulinoma. So if you have insulinomas, EUS RFA is a good modality to completely coagulate these lesions. So this is how it looks like. And if I just show you how it is being used. So these are again how the connections are made. You may not need to know this. And then ultimately you use this. So it's a very simple doing it like a FNA. You puncture with this and then you activate the RFA processor, and then you bring about the coagulation of the tissue that you intend to achieve. Again, you have to be cautious that you don't destroy the normal parenchyma, otherwise the patient will have pancreatitis post-procedure. So this is again about Ecotip fiducial needle. So fiducials are primarily, just before I go to this video, so fiducials are gold markers which are delivered through EUS FNA needles. Primary purpose is to help in image-guided radiation therapy, that is IGRT, used by the radiotherapy department. So what you are doing is you are trying to mark the lesion, say a pancreatic mass, with this fiducial gold markers, and this helps them to deliver the radiotherapy or radiotherapy at that particular site, so that damage to the adjacent organs is avoided. So still we don't have this available. I was trying to get this, but the Cook people said that it's not yet available in India. But I think in US they are doing this for the last 5-6 years or maybe more than that. So these are the bold markers which come out through the FNA needle. These are how it looks like, obviously a zoomed image. And again, 4 fiducial markers are there in this preloaded in this Cook medical FNA needle that you have. And if you see this, these are how it is. It will come out to this. These are the markers that will come out. Then EUS guided stents. I think what you just need to know is that you have different stents available. These are considered to be lumen opposing stent. And what does it mean? It means that you are trying to oppose 2 lumens to come together. And even if you remove this stent after a certain period of time, there is a fibrosis which sets in between the 2 organs and they become attached. Unfortunately, if you remove these stents, the fibrosis that it has, even the 2 organs are joined, the lumen will close. The lumen will close because you have not made a defect in the tissue. It's just an opening and stretching of the tissue that you have done. So once you remove the stents, this will again fall back. So now stents are available. These are predominantly, the diameter varies from 12, 14 or 16 millimeter, or hot axios, which is 20 millimeter in diameter. The length of this is 1 centimeter, and the length is short because you want to keep the 2 lumens very close together so that the fibrosis sets in. These are the stents. The lower row is primarily for hepaticogastrostomy that we use. So that's all. I think in instrumentation, this is all what you need to know. I think once we get in the live cases, obviously, once you see the needles being used, see the stents being deployed, at that time, I think clarity will be more.
Thank you, sir, for the crisp and precise introduction to the EUS machine. So after knowing the instrument, the next most important thing to know and understand is the anatomy of the involved organs. So I again request Professor Praveer Rai, sir, to give us a talk about the linear anatomy of the mediastinum, stomach, and the duodenum.
So I think 2 of our other faculty, somehow they are not here. So that's the reason I'll be taking up the anatomy as well. So though we have distributed this anatomy into mediastinum, from the stomach, from the duodenum, what I can tell you is that the whole lecture of the linear anatomy you can complete in just 10 minutes. But the time that we get to present linear anatomy in a conference is just 10 minutes. Having said that, here the purpose is totally different. So the purpose is, we have a time for discussion as well, but here the purpose is that you should understand whatever I am saying, and if there is any doubt, please ask. That's very, very important. So we'll come to the anatomy, and I think I'll go a bit slow on the anatomy because I think that's very, very important. Okay. So before you resort to the anatomy, it's very, very important to understand the anatomy as well as the radiology. And for this, you should be referring to anatomy books as well as radiology books. So I think the understanding is very, very important. I still remember, I think when we started doing EUS somewhere around 2010, so we used to study all the anatomy books, Gray's anatomy, then all the radiology books, just to understand how the structures exactly look like, because obviously we are not surgeons, surgeons are better than anatomy. And it's very, very important, I'll tell you, once you understand, then you'll be able to perform this EUS easily. So make the anatomy fit the station. So you should not be just passing in a scope and trying to figure out what the structure is. It doesn't work that way. You need to know what are the stations involved, and you need to know that you are at the right station if you want to understand the anatomy properly. So there are infinite number of potential windows. So what does that mean? So that means that, so ultrasound is considered to be very subjective. Why? It is considered to be subjective. Even if you see a percutaneous ultrasound, the place where you place the probe, that will give you a different image. So you have an enormous number of views that you can achieve with the probe. So that's the reason why you should be knowing where exactly to place your probe. Here you are placing your EUS scope. Obviously, the tip has got a probe that's working similar to the transducer that you are using in radiology. So very, very important. So for this, you have some important landmarks which are also known as home bases. In EUS, we say that's a home base. So what does that mean? So once you are, say, walking on a street and you forget where you need to go, sometimes you will remember, nahi, wahan mandir tha, wahan ek bada khamba tha, wahan aisa ghar tha. So that's what you need to do in EUS. You need to know some home bases. Home bases means if you are not able to see or understand, at least you should be able to see that structure and identify that particular structure. So if lost, spend some time to find your way. If unsuccessful, restart at a familiar station. So there is a term known as pulse Doppler, which helps to differentiate between an artery and a vein. Color Doppler to differentiate between vascular and non-vascular. So the only reason I'm spending time in this basics is that once you do it for 5 years, somehow at that point of time, I have seen people, they're unclear about what pulse and what color Doppler is. So these things are very, very basic things which are very, very important. Color Doppler tells you whether it's a vessel or not. Pulse Doppler gives pulses and tells you whether it's an artery or a vein. So linear scope, as I told you, has a narrow field of view, and it's critical to adopt a systematic approach to examination. Very important. Effective rotating or torquing of the linear scope is a must. So what is a torque? See, that's the problem. I think it's becoming totally unilog. So what is a torque? Rotational force. So very important. So this torque term is very, very important in EUS. Whatever you are doing, you are just torquing. So with linear EUS, the only thing that you are doing is torquing. So what is torque? So if you see this method to determine correct torquing technique, how do you know you are torquing it right? So you need to see the numbers on the scope shaft. They should rotate around the axis of the scope. What does that mean? So if you see this, we are rotating the scope, the numbers are moving. So if it's happening this way, this is a right technique of torquing. What I can tell, this looks very simple. What I can tell you is you can torque the scope in many different ways and you won't be doing it right. Okay. So see the numbers on the scope shaft, they should rotate around the axis of the scope 1 to 1. That's what the torquing is. So this is what you are doing throughout when you are using an EUS scope. So let's come to the mediastinum. So mediastinum again, now what has happened is that in mediastinum is primarily the area of the pulmonologist. But what I can tell you is when we started somewhere doing FNAs, all the mediastinal FNA here we were doing, because the pulmonary guys, they didn't have EBUS available with them. And so all these mediastinal lymph nodes, FNA, we were doing to begin with. We also do it right now off and on, but not to that extent which we were doing earlier. So this station that I'm mentioning is not the station of imaging. This is, I'll just come to that. This is the ISLC classification of lymph nodes for lung malignancy. So this is what it is. Station 1, don't confuse this station with the station of imaging that I'll tell you. So station 1, this is primarily for the lymph nodes, this is neck. So this is what the station 1 is. So people demonstrate that you are able to see the arch of aorta, and then you are able to see the takeoff of the subclavian. To me, it doesn't make any sense. If you just bring the scope too up, the patient will start coughing. It becomes very difficult. Moreover, this you can do very well by clinical examination as well as a percutaneous ultrasound guided FNA. So this is what the station is. So if you see the stations, as I mentioned, this is station 1, 2, and 3 are predominantly in the cervical region. Rest of these stations, station 4 to 9, are the ones that we see with endoscopic ultrasound. Then you have station 11 to 14, which you cannot see on endoscopic ultrasound. This is the reason why you need an EBUS for that, endobronchial ultrasound. As you can see, these are available only when you enter into the bronchus. These are not near the trachea or not near the GI esophagus that you are imaging, where your scope is placed. So 11 to 14 are not, you cannot FNA that with EUS scope. So this is what we are dealing with predominantly: mediastinum above carina 2 to 6, below carina 7 to 9, predominantly by EUS. This again, as I was mentioning, International Association for Study of Lung Cancer. These are lymph node stations that I'm talking of. This is what their station looks like. This was way back published in 2009, 14 stations. So once we talk of the station-based approach in the mediastinum, there are 3 important areas that you can look for. That is the lower esophagus, the mid esophagus, and the upper esophagus. So these are the important areas that you want to look for. Again, the same figure. This figure is very, very important, and you really need to know this figure just to have an understanding where exactly these lymph nodes will be situated. So the technique of evaluation of the mediastinum is a very straightforward technique. Why it is straightforward? Because the esophagus is a linear structure. You pass your scope in, and if you just pull your scope back, the whole examination of the mediastinum is done. What you have to do is to apply torque. So you are torquing your scope throughout, say at a 2 to 3 centimeters in the mediastinum, and whole examination of the mediastinum is done. Importantly, what you have to remember from the point of view of real life scenario, in mediastinum, you will primarily be targeting the lymph nodes for an aspiration or a biopsy. That's what the whole purpose of evaluation of the mediastinum is. Kindly don't get confused with all the vascular structures, the left atrium, right atrium, aorta, pulmonary artery. You obviously should be knowing these structures, but I would say don't try to go in too much deep into that. It's not required. Clinically, it's not going to help you out. So rotate 180-degree clockwise, aorta, rotate 180-degree clockwise, counterclockwise. You are done with the examination. If you just keep on withdrawing 1 to 2 centimeters and doing this maneuver. So mediastinum, it's quite straightforward. So let's see. This is what you have done is you have positioned your scope in the lower esophagus. So as soon as you position your scope in the lower esophagus, what you need to know is when the probe is facing anteriorly, what will you see? So at the G junction, if you position your scope and the scope tip, that is the probe, is facing anteriorly, what will you see? Sorry? Liver. If you turn your scope posteriorly, what will you see? aorta. So this is very, very important. So what is your home base? Your home base becomes liver. Whenever you're getting confused, go at the G junction, rotate, you see this liver, you rotate, you see the aorta. So these are the home bases you need to understand. Okay. So this all imaging we will show you when we do live cases. This is the typically left lobe of the liver. This is the IBC. You will see the intrahepatic portion of the IBC. This is not shown in this. I'll just show you on the video. And once you trace this intrahepatic portion, it's going up into the mediastinum. It will open into the IBC will open into the right atrium. This you can very, very easily see on EUS. So we'll demonstrate that. And here, the region where IBC enters into the right atrium, this particular area is station 9. Okay. So station 8 and station 9, these are lower paraesophageal. Okay. So to be honest, 8 or 9, you will never need to tell anyone while doing a real life scenario cases. No one wants that. If you get a lymph node in that region, you do an FNA, you get a diagnosis. No one will ask you whether you have sampled station 8 or station 9. At least for gastroenterologists, it's not that relevant, but at least you should be knowing. So station 8 is above. So if you see this image, station 8 is above. Station 9 is typically pulmonary ligament. Okay, pulmonary ligament, but both of these are just paraesophageal, lower paraesophageal. This is how I would label it. Very close would be station 8, and just slightly far off in the pulmonary ligament is station 9. How to reach this, how to approach, I think we'll just cover that. So if you place your scope at the G junction, see the intrahepatic portion of the IBC, trace the IBC to the right atrium. The station, that is the area that you see adjacent to the probe, is station 9. Is that clear? That is station 9. So this is the video. If you see this, so this is the intrahepatic portion of the IBC. This is a hepatic vein. Which hepatic vein? Right hepatic vein. So why right hepatic vein? Okay, so I just tell. So see again, imaging of liver segments, I think I have not included here, but what I will tell you is it's good to know it. Sometimes it's difficult, but it's good to understand. So if you have a good knowledge of your anatomy, you will be able to understand it very easily. Whenever you are seeing the intrahepatic portion of the IBC, the vein that you will see is an RHV. Okay, that is an RHV. RHV has wider opening while it goes into the IBC. So RHV is not uniform throughout its course. It has got wider neck when it inserts into the IBC. That's how you see. And then it will start tapering throughout. This is what the RHV is. When you are seeing RHV, you are seeing intrahepatic portion of the IBC. This segment here is segment 1. Okay, good. You are seeing intrahepatic portion of the IBC. This is RHV. What is this segment? बताओ भाई 8. Who are saying 8? Because they are right. Who are saying 8? No one is saying 8. अरे भाई सीटी स्कैन में देखते हो आरएचबी अगर दिख रही है, आरएचबी के राइट साइड में कौन सा सेगमेंट है और लेफ्ट साइड में कौन सा सेगमेंट है बताओ? अपर में वी आर अप 7 and 8 कौन सा साइड में होगा, कौन सा मिडिल होगा? मीडियल 8. ये क्या है? ये medial है lateral है RHP के lateral है medial है भाई यार ये 8 है ये 7 है 7 सबसे ऊपर चला गया okay so this is RHP this is 8 this is 1 this is 7 is that clear there is no doubt about it okay so once you figure out RHP you can figure out about what liver segment it is 1 8 and 7 okay then what you do so what I'll do here is I'm just following this is IVC so this video is not very good if you see now this is IVC going into the right atrium okay this station here this is obviously not the station this is the vessel this you will have lymph nodes here if you find a lymph node here that is station 9 okay so this is station 9 so this is lower esophagus that's it lower esophagus में इसके ऊपर थोड़ा सा अगर आप स्कोप को पुल करेंगे और आपको लिम्फ नोड नजर आ गए वो क्या है दैट आर लोअर paraesophageal that is station 8 okay that's the reason I'm saying it's important to understand and know the anatomy okay so then if you see the mid esophagus is the most important area because here you have importantly two important spaces that I'll talk of one is the subcarinal space another is the AP window okay okay so subcarina space means below the carina that is clear so this is station 7 and it is above the station 8 so is that clear so as if you can figure out the bifurcation of the trachea area below it will be subcarina this is the knowledge that you have on EUS how you reach to that particular area I'll come to that so here what we are trying to do is so please now don't confuse this area 7 area 5 with 5 and 6 so this 5 and 6 I'll come to that when you are doing a linear anatomy to make things easy what has been done station 1 is beyond the papilla okay these are stations for imaging these are not for lymph nodes station 1 is beyond the ampulla station 2 is at the ampulla station 3 is at the level of duodenal bulb station 4 is at the level of stomach below the G junction station 5 and 6 are in the mediastinum that's what this 5 and 6 means okay so this is just to make you or everyone on the same page if I say that I have examined station 1 that means I have examined unsealed area if I say I am examining station 5 and 6 that means I am examining mediastinum okay this obviously may be different you can even say that you are examining the mediastinum no one will tell you that you tell me which station it is okay it doesn't matter this is just for the sake of learning station 1 2 3 4 5 and 6 these are stations of linear imaging of the whole abdominal area so subcarinal space is very important why it is important because this is the most common area where you will find the lymph nodes and from where you will sample subcarina okay so what is subcarina is typically between the left atrium and the pulmonary artery so ये थोड़ा move हो गया है so this subcarina is here this is the left atrium and this is the pulmonary artery so this area between the left atrium and the pulmonary artery is the subcarina okay so how to reach there so just this is first a diagrammatic representation to make you understand so what you were doing is initially I told you that you see the IVC reach the right atrium from right atrium just you pull the scope further ऊपर की तरफ और scope को खींचना है then what you will see right atrium के बाद आपको left atrium नजर आ जाएगा slide up on the up down knob so this is very important that you have to keep your probe attached to the wall. That is very important for EUS imaging. So whenever I say, I use this terms quite a lot of times, up on the up down knob. Up down knob पे knob को up रखिए, उससे आपका probe जो है वो wall को touch करेगा. Okay, and that's how you image. So if you are up on the up down knob with slight clockwise anti-clockwise rotation, you will see a large pulsatile structure which is the left atrium. लेफ्ट एट्रियम से आप स्कोप को बस थोड़ा सा और ऊपर खींच देंगे तो आपको राइट पल्मोनरी आर्टरी नजर आए. ओके, I'll just show you this, and in live also we'll show you, not a problem, but just to make you understand how we are approaching the different stations. So what it is, आपको लेफ्ट एट्रियम नजर आएगा, राइट पल्मोनरी आर्टरी नजर आएगी. इन दोनों के बीच का एरिया इज स्टेशन 7. You have already seen station 9, you have seen station 8. Now you are seeing station 7. जब आपको लेफ्ट एट्रियम नजर आएगा, आप थोड़ा सा और एंटी क्लॉकवाइज रोटेट करेंगे तो आपको मिडल वॉल बहुत अच्छे से नजर आएंगे, एंड यू विल सी द लेफ्ट वेंट्रिकल. At the same time, you will see here the ascending aorta. Okay, ascending aorta, and beyond this you will see the pulmonary trunk. ये इसमें इमेज में नहीं है, ये देखो पल्मोनरी ट्रंक बना है. यही पल्मोनरी ट्रंक जाके डिवाइड करेगा ऐसे to the right and the left pulmonary artery. Is that clear? So subcarina is bounded by left atrium and the right pulmonary artery. Okay, I'll just show you that. So again same intrahepatic part, ये आपने aorta से पुल, sorry, IVC से पुल किया, station 9 आया, लेफ्ट एट्रियम है, ये लेफ्ट एट्रियम से आपने थोड़ा सा पुल कर दिया, ये राइट एट्रियम से लेफ्ट एट्रियम आ गया. कैन यू सी दैट? So what you are doing, you are just pulling. So if I just show you the structures here, ये लेफ्ट एट्रियम है, ये मिट्रल वॉल है, ये लेफ्ट वेंट्रिकल है. क्या कर रहे हैं आप थोड़ा बस पुल कर रहे हैं, अप ऑन द अप डाउन नॉब है, क्लॉकवाइज एंटी क्लॉकवाइज घुमा रहे हैं, और ये थोड़ा एक्सपीरियंस से आएगा. ये मेरे एक बार बताने में आप कर देंगे तुरंत आपको दिख जाएगा, ऐसा नहीं होने वाला है ना. सो आगे क्या है, ये लेफ्ट एट्रियम है, ये मिट्रल वॉल है, ये लेफ्ट वेंट्रिकल है, ये एओर्टिक. लेफ्ट वेंट्रिकल से क्या निकलेगा? एओर्टा. ये एओर्टा है, ये एओर्टा के वॉल नजर आएंगे आपको, ये एओर्टा निकल रही है यहां से. दिस इज एओर्टा, जस्ट सी दैट. ये कैन यू सी दिस? दिस इज एओर्टा, एओर्टा है ना. अब क्या हुआ, आपने खींचा, लेफ्ट एट्रियम था, एक स्ट्रक्चर यहां नजर आ गया, ये पल्मोनरी आर्टरी. ओके, कौन सा पल्मोनरी आर्टरी है? राइट पल्मोनरी आर्टरी. ये स्पेस जो आ गया, दिस स्पेस सब क्या है, अगर आप नंबर्स भूल जाते हैं तो आप याद रखिए सब कह रहा है, स्टेशन 7. ओके, फिर पुल किया आपने, पुल करते गए, ये आप देख लीजिए, दिस इज एओर्टा, एओर्टा निकल रही है, ये बड़ा सा लिम्फ नोड आ गया, और सब कह रहा है ना, लेफ्ट एट्रियम, राइट पल्मोनरी आर्टरी. सो इज दैट क्लियर? दिस इज द मोस्ट इंपॉर्टेंट स्टेशन. प्रैक्टिकली आपको यही मिलेगा, यही लिम्फ नोड्स मिलेंगे, एंड यू विल नीड टू सैंपल दिस. ठीक है. Another very important landmark is AP window, and what I can tell you is, this is based on experience, that subcarina you may find lymph nodes which are not pathological. AP window, if you are getting lymph nodes, it is usually pathological. Very important to understand. Here, if you are just finding small lymph nodes also, I'll go ahead and do an FNA if I don't think there is any risk involved. I'll do an FNA because here if lymph nodes are present, these are usually pathological. इसमें क्या होगा? So just understand what is the AP window. So AP window is primarily, so if you see this, this is the aortic arch, and this lymph node station below the aortic arch is station is your AP window, aortopulmonary window. So this is pulmonary artery on the left and aorta on the right. ये pulmonary artery, left pulmonary artery. Is that clear? वहां क्या था? right pulmonary artery थी. ये left pulmonary artery है, aorta है, इन दोनों के बीच में जो space है, this is, अब इसमें मैं थोड़ा सा बता दूं, इसमें this station upper one is 4L. Okay, 4L. यहां पे ये लिगामेंट होता है, इसके नीचे जो है ये स्टेशन 5 है. ओके, सो 5 को टिपिकली स्टेशन एपी विंडो कहा जाता है, So many people, even to 4L, they will say it's an AP window, but that's okay. But you need to know AP window is typically station 5, which is here, not here. Here it is 4L. Okay. So if you see this, क्या हो रहा है? Scope हम और ऊपर ले आए, left pulmonary artery, aortic arch. कैसे यहाँ पहुंचेंगे? I'll just tell you. Aortic arch आ रही है, left pulmonary artery आ रही है, ये station 4L है ऊपर की तरफ, ये नीचे की तरफ 5 है. Aortic arch के पीछे जो एरिया है वो स्टेशन 6 है. लेफ्ट पल्मोनरी आर्टरी की जो पीछे दिख रहा है वो स्टेशन 10L है. ओके, आज ही सब कुछ याद नहीं हो पाएगा, इसको याद करने में टाइम लगता है काफी, बट यू नीड टू अंडरस्टैंड हाउ यू लोकेट दीस एरियाज. ओके, सो इफ आई जस्ट समराइज इट, एओर्टिक आर्च के पीछे स्टेशन 5, इधर प्रोब के जस्ट पास 4L, बियॉन्ड दिस स्टेशन 5, लेफ्ट पल्मोनरी आर्टरी के बियॉन्ड स्टेशन 10L. Very important to remember. Now just see on imaging. So the method is, what you do, as I mentioned, it's very important to know your home base. Okay, I have told you how to locate the subcarinal area. You go to the G junction, locate the liver, see the intrahepatic portion of the IBC, trace it, the IBC to the right atrium, further pull up, trace the left atrium, further pull up left atrium and the right pulmonary artery. In between the space that you get is the subcarina. Here what you do, this space as you see is just above it. What you do is, in the mediastinum, you rotate your scope to locate the aorta. That's the first step. क्या कर रहे हैं आप, ये देखिए, आपने aorta locate की पहले, है ना? You are locating the aorta. Aorta के पीछे ये mirror image आती है. This is known as reverberation artifact, which is part of the EUS imaging. So aorta, mirror image of the aorta, the reverberation artifacts, and once you reach the top of the aorta, this aorta has started arching. Okay, that is the arch of aorta. इसके ऊपर अगर आप चले जाएंगे तो आप नेक में पहुंच जाएंगे और आपकी लेफ्ट सबक्लेवियर आर्टरी आपको नजर आएगी इससे निकलती हुई. I would say we don't need that. So what here you will do is, if you see this aorta, what I have done is, aorta, once the aorta starts arching, scope को अपना 1 सेंटीमीटर आगे ले जाइए. Okay, rotate clockwise 60 degree. ठीक, this is the method how to see the AP window. What you do, see the aorta, trace the aorta to the aortic arch. Once you reach the aortic arch, push in a centimeter, rotate clockwise to 60 degree. Rotate clockwise or to around 60 degree. What you will see. So if you do this, ये मैंने क्या किया, आर्च हो गई, फिर मैंने पुश किया और रोटेट कर दिया, तो क्या हुआ, तो मुझे दो स्ट्रक्चर नजर आ रहे हैं. यहाँ तो एओर्टा थी जिसपे मैंने आर्च से मैंने आगे पुश किया है. ये क्या है, left pulmonary artery. So left pulmonary artery on the left side, right side is the aortic arch. This area is station 4L. Okay, this is station 4L, this is station 5. आगे चला रहा हूं मैं. Just see this. This again patient who had obviously lymphadenopathy. So you can see right side में aortic arch आ रही है, left side में pulmonary artery आ रही है. अब मैं इसको पोजीशन कर रहा हूं, ये large lymph node AP window में है आपका. Okay, so here if you see 4L, 5, this is 6, this is 10. अगर lymph node आपको यहां दिख गया ये 10L है, आप FNL नहीं ले पाएंगे. 6 है, FNL नहीं ले पाएंगे. क्यों? क्योंकि आप इसको थ्रू जाना पड़ेगा. ओके, तो ये I think so 4L, 5, 10L and 6. I think I'll just position that where ultimately it will be there in the end. 4L ऊपर है प्रोब के पास, 5 नीचे है, beyond the aortic arch 6 है, ये है. Okay, so this is what you need to know. अभी लास्ट पार्ट है अपर इसोफेगस का. आई थिंक आई जस्ट skip this. It's not required practically, real life scenario it's not needed. Just to make you aware, I'll just tell you 2L कहाँ होता है. जब एओटिक आर्च है, जो मैंने बोला कि एओटिक आर्च अगर आपको मिलेगी यहां से, जो अगर आप नेक पे ले जाएंगे तो लेफ्ट से सबक्लेवियन निकल रही है. लेफ्ट सबक्लेवियन के बगल में जो लिम्फ नोड्स आएगा वो आपका स्टेशन 2L है. इज दैट क्लियर? ऐसे ही 3 के लिए आपकी लेफ्ट सबक्लेवियन निकल गई. लेफ्ट सबक्लेवियन के पीछे यहां पर मैंने 2L बताया था, ये स्टेशन 3A. ओके, this is not needed in real life scenario. Okay, so I think coming to the anatomy of the stomach and the duodenum, I'll just quickly run through this. So as I was mentioning, 1 is beyond the papilla, 2 is at the level of papilla, 3 is at the level of bulb, 4 is in the stomach, and 5 and 6 are in the mediastinum. Okay, that should be clear. These are stations. अब जब आप अपना स्कोप बियॉन्ड G2 करते हैं, the structure that you need to look at is the aorta. अगर आपको aorta नहीं दिख रही है तो आप दोबारा से जाइए. क्यों? You can say that the pancreas, the part of the pancreas that you're visualizing, is the uncinate only if you are able to locate the aorta. Okay, then you are going beyond D2, beyond the papilla, then you should be seeing the aorta. Once you see the aorta, the part of the pancreas which is between the probe and the aorta is the uncinate part of the pancreas. Okay, just a quickly video दिखा रहा हूं मैं. So this is, you see there are 2 structures. एक ये है, एक ये है. Okay, ये aorta है, ये IVC है, दोनों पैरेलल रन करती हैं उधर. So IVC has got thinner walls. Obviously, you can apply the pulse Doppler to find which is artery, which is vein. Normally, you will not get confused. This is the aorta. This is the IVC. If you see this aorta, when you see the linear anechoic structure aorta, you are pulling back. The part of the pancreas that comes into the picture is an uncinate part of the pancreas. That's it. इतनी ही आपको anatomy देखनी है beyond D2 से. This is very, very important to sample lymph FNA from the uncinate process. And what I can tell you is this is the most difficult part of the examination of EUS beyond papilla. क्यों? क्योंकि अनस्टेबल होता है, वो दिखता नहीं. कई बार एओर्टा नजर नहीं आएगी आपको. एओर्टा नजर नहीं आएगी तो मुझे आई एम नॉट श्योर वेदर यू कैन रियली कमेंट द अनसिनेट पार्ट हियर. इट कैन वेल बी हेड टू द पैंक्रियास. ओके, सो वंस यू सी दिस, ये IVC है, you can see IVC, ये एओर्टा. अब मैंने एओर्टा को पिक्चर में रखा. क्या मूवमेंट हो रही है? जस्ट क्लॉकवाइज, एंटी क्लॉकवाइज मूवमेंट एंड पुल बैक. दिस व्हाट यू आर डूइंग. ओके, ये आ गया लार्ज मास, आ गया ये लार्ज मास ऑक्यूपाइंग द अनसिनेट इन द हेड है. और फिर आपको एनीकोइक स्ट्रक्चर नजर आएगा. दैट एनीकोइक स्ट्रक्चर हियर, दिस व्हाट इज स्ट्रक्चर. और कुछ हो सकता है? और कुछ हो सकता है? Bile duct. Okay, I'll just show you further. So once you pull, then you will see aorta. The part you are seeing is uncinate. Beyond, if you just keep on pulling, you will see the pancreatic duct. You will see the CBD. Okay, CBD will be nearer to the probe. Further from the probe, there is a pancreatic duct. दूर उससे pancreatic duct होगी. And then this is the ampullary region. This to me is a very unstable position. I don't usually image at this particular position. Either I do it at the bulb or I do it beyond the papilla. So if you see this, this is the typical crescent-shaped pancreas that you see when you're imaging from the level of ampulla. You can see the pancreatic duct here, and you can also see the bile duct. Okay. So आपका scope ऐसे positioned है. You can see ये पार्ट ऑफ बाइल डक्ट आप देख रहे हैं नियर टू द प्रोब. ये पैंक्रेटिक डक्ट है, ये फर्दर फ्रॉम द प्रोब. ओके, Then this is station D3, station 3, that is from the duodenal bulb. This is the most important position from where you will figure out all these stones in the CBD. You will figure out a small mass at the ampulla. You will do all FNAs from the head of the pancreas from this particular area. So what you have to do is you have to take your scope and position your scope at the superior duodenal angle of the duodenal bulb. That's the very crucial apex of the bulb पे आपको scope रखना है. Once you do that, this is what you will see. You will see portal vein. ये इसको ऊपर ट्रेस करेंगे, लिवर में जाएगी. ये splenic vein आती है. ये नीचे की तरफ superior mesenteric vein जाती है. Okay. If I show this on video, so this is a grossly dilated bile duct, and what I have done, you can see I have instilled a lot of fluid. Lot of fluid I instill when I am doing EUS imaging. This is primarily to get a good acoustic coupling. Radiologist क्या करता है, ऊपर जेली लगाता है. आप जेली लगा नहीं सकते. आप पानी से भरते हो, which does the same job as applying jelly. So is that clear? So to get a good coupling, otherwise you will have a lot of artifacts. तो इसमें क्या कर रहे हैं हम लोग? इसमें देखिए, ये जो पार्ट आ रहा है, ये पूरा पैंक्रियास है, ये बाइल डक्ट है, ये छोटा सा मैस है पैंक्रियास, ये बाइल डक्ट के लोअर एंड में, और ये ड्यूडेनम आ रहा है इधर पूरा, है ना? दिस होल ड्यूडेनम. So you can see this. So what I am doing, ये बाइल डक्ट जा रही है लिवर के अंदर, मैं ट्रेस कर रहा हूं उसको, ये लिवर के अंदर बाइल डक्ट. So just to show you again, ये बाइल डक्ट है, बाइल डक्ट है. इसके पीछे पोर्टल वेन आती है, very important. Bile duct nearest to the probe, further from the probe will be portal vein. And if you just trace this, bile duct को lower end की तरफ trace करने के लिए clockwise movement of the scope होता है ना? GB देखने के लिए D1 से anti clockwise movement होता है. तो इसको अगर आप trace कर रहे हैं तो ये छोटा सा mass आपको नजर आ रहा है lower end पे. Okay, this is a very small mass. This patient is still on follow-up, 2014. So we were confused कि इनको malignancy है कि नहीं. Okay, so this FNA was done from this, which was negative. Okay. So this again station stomach station 4. This is very important. Here primarily the transducer is advanced by the aorta. सब आपने क्या किया? आप G junction पहुंचे, liver आपने देख लिया था. वहां से अगर आप 180 रोटेट करेंगे, आपको aorta नजर आएगी. Okay. So you take your scope at the G junction with the probe positioning and position anteriorly. You will see the liver. If you rotate 180, you will see the aorta. Once you see the aorta, you trace the aorta. You will see the takeoff of the celiac. You will see the takeoff of the SMA. Okay, very important. Position scope कहाँ है आपका? Scope आपने यहाँ पर रख दिया. Aorta है ये. Aorta से ये निकल रही है celiac और SMA. आपने scope यहाँ पे रखा है. So how do you do this? If you see aorta and then celiac. Can you see the celiac? This is the celiac. This is aorta. This is celiac. And celiac के just नीचे SMA आए. Okay? Aorta, celiac. और if you from this celiac आ रही है और celiac के नीचे SMA आती है. If you consider that two fingers, they are pointing towards pancreas. Okay, so if you just push in your scope slightly, you'll follow the pancreas. So this pancreas is not a normal pancreas. The typical normal pancreas is a typical salt and pepper appearance. Smooth होता है ना? ये तुम देखो कोर्स दिख रहा है आपको, ऐसी देखने से कोर्स दिख रहा है. तो इसको आप देख के बता देंगे ये गड़बड़ है pancreas. So इसमें आप have got many features: hyperechoic foci, hyperechoic strands, lobules, presence of calcification. So these are the features which tells you that the pancreas is abnormal. If you have more than 4 features, it tells you that the patient is having underlying chronic pancreatitis. इसमें क्या क्या दिख रहा है मुझे? ये hyperechoic foci छोटे-छोटे हैं, hyperechoic strands बड़े-बड़े हैं. ये मुझे lobules नजर आ रहे हैं. Can you appreciate the lobules? अगर आपको pancreas में lobules नजर आ गए, आपकी diagnosis CP की बन गई. Provided आप सही देख रहे हैं और सही diagnosis बना रहे हैं, है ना? Because it's again very subjective. वो कुछ बोलेंगे lobules है, कुछ बोलेंगे lobules नहीं है. लेकिन ये वाला जो मैंने आपको केस ये दिखाया है, इसमें जो भी यूएस करता है वो बोलेगा ये lobule. Okay. Lobule, what is a lobule? Lobule is a hypoechoic area bounded by hyperechoic areas or hyperechoic strands. Okay. So बीच में काला है, bounded by white. That is what lobule is. Okay. So इसको अगर आप देखिए, so if you see this is the pancreas. As I mentioned, this is not a normal pancreas. This patient, if is not having calcification, then definitely I would say he established early chronic pancreatitis है patient को. And once you see the pancreas, then what you do is you rotate your scope clockwise with a full back. क्या किया आपने? आपने स्कोप को, आपने एओटा देखी, पुश कर दिया, पैंक्रियास आ गया, पैंक्रियास से आप क्लॉकवाइज रोटेट कर रहे हैं और स्कोप को पुल कर रहे हैं. क्यों कर रहे हैं? क्योंकि अब आपको अगर लेफ्ट के स्ट्रक्चर्स देखने हैं तो आपको क्लॉकवाइज जाना पड़ेगा, और पुल इसलिए कर रहे हैं क्योंकि स्प्लीन जो है थोड़ा ऊपर की तरफ होता है ना. So यहाँ से अगर आप देखें, so if you are seeing pancreas, after that what you do is clockwise with a pull. अगर clockwise with pull करेंगे, you will see the kidney, then you will see the adrenal, then you will see the spleen. Okay? और फिर splenic hilum आप देख पाएंगे. So this is what movement is right now. If you see this is the pancreas, this is the kidney. Kidney is typically identified by cortex and medulla, hyperechoic and hypoechoic. And then if you just rotate, मैं रोटेट कर रहा हूं, किडनी खत्म, स्प्लीन आ गई. क्लॉकवाइज रोटेट विद अ पुल बैक, है ना, स्कोप, क्योंकि स्प्लीन थोड़ा ऊपर की तरफ, ये किडनी आ गई, ये स्प्लीन आ गई. ओके, दिस इज द स्प्लीन. ये पैंक्रियास का टेल है. यू आर एबल टू डिलीट द पैंक्रियाटिक टेल नाइसली. ओके, देन ये क्या है? ये हाइलम है. ये स्प्लेनिक हाइलम है जिसपे स्प्लेनिक वेन, स्प्लेनिक वेसल्स एंटर कर रही है. स्प्लेनिक आर्टरी, स्प्लेनिक वेन. Can you see this? This is the hilum. यहां से आप वापस जा सकते हैं, है ना. So यहां से आप वापस जा सकते हैं. तो स्प्लेनिक वेन आ गई, स्प्लेनिक हाइलम, स्प्लीन है. वापस जाएंगे तो क्या दिखेगा? आपको किडनी दिखेगी, किडनी के ऊपर एड्रिनल देख सकते हैं आप. एंड ये जो, कैन यू सी दिस नाउ? दिस वन. So this is what the adrenal is. This is typically known as flying bird sign or the seagull sign. Okay, seagull sign or the flying bird sign. ये किडनी के just ऊपर आपको adrenal नजर आएगा. You can easily take an FNA or a biopsy from an adrenal gland if required. वो सब endocrinologist कर लेते हैं और performance करा देते हैं. But obviously you can do it very easily without any problem. So ये आपको adrenal दिख गया. फिर किडनी आ गई वापस. यू आर गोइंग बैक, यू फॉलो द पैंक्रियास अगेन. एंड यहां से अगर आप, नाउ यू सी, ओके, I'll just show you something here important again. ये तीन आ गया, वापस जा रहे हैं आप, किडनी आएगी, ये एड्रिनल आ गया, एंड देन हियर पैंक्रियास आ गया, और पैंक्रियास में आपको ये, ओके. So I think that's very important. That's the reason I want to show you. ये क्या हो रहा है पैंक्रियास में? यहाँ पे क्या, what is this structure? Can you tell me? You are looking at the pancreas from the stomach. What is this structure? What is this? What is this? Not a very good imaging, but this all we will see when we do the case. है ना? Don't परेशान होने की जरूरत नहीं. We will see all these structures. ये स्प्लेनिक वेन आ रही है. ये स्प्लेनिक वेन है. ये नीचे से सुपीरियर मेसेंट्रिक वेन आती है. ये पोर्टल वेन आएगी. इसको आप ट्रेस करेंगे, लिवर में चली जाएगी. ओके, स्प्लेनिक वेन अगर आपको दिख रही है, इसके बगल में एक और स्ट्रक्चर जो कि नियर टू द प्रोब है, वो स्प्लेनिक आर्टरी. इसको आप अगर अच्छे से ट्रेस करेंगे, दिस यू कैन ट्रेस इट फ्रॉम द एओर्टा, सीलियाक, स्प्लेनिक, वो आपको दिख जाए. ओके, तो ये पोर्टल वेन है. ये पैंक्रियाटिक डक्ट है, दिख रही है. Okay, so I'll just let it play because it's somehow rushing. Okay, so ये स्प्लेनिक आर्टरी है. ऊपर स्प्लेनिक आर्टरी है, ये स्प्लेनिक वेन है, ये मैं लेबल कर रहा हूं। तो दिस इज स्प्लेनिक वेन, दिस इज सुपीरियर मेसेंटेरिक वेन, नीचे से आ रही है ये, और ये पोर्टल वेन बन गई है, कॉन्फ्लुएंस है। सो अगर ये कॉन्फ्लुएंस है, ये स्प्लेनिक वेन है, ये कौन सा पार्ट हो गया पैनक्रियास का? नेक ऑफ द पैनक्रियास। ये नीचे वाला क्या हो गया? हेड ऑफ द पैनक्रियास। ओके, so you are able to see the neck of the pancreas, you are able to see the head of the pancreas. ये घुस गया लिवर में इधर। Can you see this now? Portal vein entering into the liver. ये that portal vein we have traced. So it's all a matter of tracing the structures. This is portal vein in the liver. Portal vein के just नीचे क्या आएगा? Liver, hilum पे, CVD. Okay, so you can very well visualize the CVD from the hilum. Okay, so ये आपकी पोर्टल वेन आ गई, ये आपकी बाइल डक्ट आ गई, ये आपका हाइलम ऑफ द लिवर आ गया। Okay, so again, systematic approach to examination is a must. Make the anatomy fit the station. Effective torquing. Each patient's anatomy is different. Successful and complete imaging may be challenged in some patients. Doing more and more is the key. So I think I've taken a lot of time actually, because I thought this we can cover very quickly. So I have got 2 more lectures, but I think because we have too many cases also, we have got I think at least 12 or 14 cases lined up. Okay, so I think doing cases would be more effective than taking lectures. You want me to cover some part of FNA? Okay, so we'll just quickly go through FNA. I will skip the pancreatic fluid collection drainage. I'll talk about FNA, and so just so that once we do FNA, you are aware of what we are doing. Some issue? क्या हुआ है? Your screen is paused. Okay, so I'll just skip through the theoretical part. I'll just come to the practical aspects of doing the FNA. Is that right? Okay. So I'm not going into the indications and the contraindications. Contraindications obviously are the same of any endoscopic procedure. So technical aspects, I think, verify the indication, localize the lesion and position the endoscope, choose the correct needle, insert the US FNA needle into the endoscope, position the lesion in the needle path, puncture the lesion and move the needle within the lesion, withdraw the needle and process the aspirate, prepare the needle for subsequent passes. So these are the steps that you need to know about US FNA. So we'll not go into any theory. We'll just talk about these technical aspects. So before US FNA, it should be clear that the information obtained has a reasonable chance of being clinically useful. So you should only be doing an FNA if it's going to impact management. If it's not impacting management, you should not be wasting the time and money of the patient. Should be avoided if it's not clearly does not there's management. There is a risk of tumor seeding that would worsen outcome. There is an excessive risk of FNA related complications, that is bleeding, infection, and trauma to the surrounding structure. Whenever possible, the echo endoscope should be straight. So very important. क्यों? Echo endoscope straight इसलिए होना है कि आपको device needle निकालने में आसानी हो. You should be easily, otherwise you will damage the channel. जब बहुत angulated position होती है, especially in deep D2, then you may have tough time taking out the FNA or FNB needle, especially the thicker needles. Okay. अब यूएस का पोजीशन, स्कोप का पोजीशन स्ट्रेट हमेशा आप नहीं कर सकते. इसोफेगस में देयर इज नो इशू, यू कैन स्ट्रेटन द स्कोप, बट इन द say deep D2, it's very difficult to straighten the scope. How do you do that? If you shorten to some extent, your upper end is moving, it's like this, it's an oblique scope, you will have tough time to pass the needle. This makes needle movement easier, reduces the risk of damage to the X-ray channel. So these are the parts of the needle that you need to be aware of. So you have a scope lever attachment. ये needle scope के channel में यहाँ fix होगी. That's what the lever arrangement is. Sheath adjusting lock. इसको आप खोल के you can adjust the length of the sheath. Then you have the needle depth log, इसको यूज करने से needle कितनी लंबी निकलेगी, that it will bring out that much amount of length of the needle. And then this is the needle handle and this is the stillet cap. So this is the handle, इससे आप grasp इसको ऐसे करते हैं, and then this is the stillet cap. So these are the part of the US FNA needle. So as I mentioned, we are using this is Boston needle. We are using this needle. Steps क्या है जो मैंने दिखाए? सबसे पहले आप इसको फिक्स करेंगे, आपने रोटेट कर लिया लीवर लॉक से, उसके बाद आपने स्टिलेट को थोड़ा पुल कर दिया, पुश कर लिया. तो पुल क्यों कर रहे हैं स्टिलेट को? अब ये स्टिलेट ना, स्टिलेट there are many issues with स्टिलेट. क्यों बना था स्टिलेट? स्टिलेट was made because the assumption was when you puncture the GI wall, then some amount of part of the wall or something can stick to the tip of the needle. उसको आप dislodge कर देंगे अगर आप स्टिलेट यूज कर रहे हैं. Are you able to understand? Otherwise, suppose आपने उसको dislodge नहीं किया, वो जो aspiration वाला काम है होगा नहीं. This was the concept with which this was made. I think recently I was in some meeting and there this stillet was made possibly by Peter Willman, and he was there in the meeting. But now there are many studies which tell you that stillet is not required. This is what many studies tell you now. You do with or without stillet, it does not matter. But this was the pretext based on which stillet was introduced. Okay. So once you have done that, position the lesion in the needle path, target and project the needle. आप length adjust कर रहे हैं, sheath की length आपने adjust कर दी और आपने needle की length adjust कर दी. And then if you are doing suction, so again normally what you do is, now there are studies to tell you that with or without suction it does not make a difference. However, the practical part that I will tell you is that in all passes we go first without suction. If we don't get sufficient material, we use suction. Okay, studies tell you with or without suction doesn't matter, though there are guidelines, ESG guideline है जो बोलती है कि 10 ml suction, 10 ml syringe का suction routinely सब में use करना चाहिए. But just logical thinking is, when there is a hard lesion like pancreatic adenocarcinoma, जिसमें suppose in the setting of chronic pancreatitis you have so much of desmoplastic reaction that अगर आप suction नहीं लगाते तो material नहीं आता. अगर suppose कोई soft structure है जैसे lymph node, अब lymph node में आप suction बहुत लगा देंगे तो blood आ जाएगा. Okay, so the practical aspect is first pass without suction, see the aspirate. If it's okay, you do again without suction. If there is no sufficient material, you apply suction. That's what the logical thing is. Okay, suction कैसे लगाना है? अभी आप देखेंगे वहां भी अगर suction use करते हैं, ये syringe में आपने negative pressure create कर लिया और आपने इसको पीछे उसके needle के tip पे आपने इसको लगा दिया. This is how it is loaded, negative suction. जब आपने lesion, when you have punctured into the lesion, before puncturing, it's always mandatory to apply Doppler. आपको Doppler जरूर लगाना है so that you are not going through a vessel. Once you have entered into the lesion, एक तरीका है, आपने सबसे आसान तरीका क्या है? सबसे आसान ये है कि आपने needle अंदर कर ली और आप इसे अंदर बाहर ऐसे कर रहे हैं बस, क्योंकि आसान होता है, आपको कुछ movement नहीं करनी. But what needs to be done is fanning. This is more applicable for an FNA. Now, since we are gradually shifting to FNB in majority of the cases, fanning again is needed, but you do not need to fan the whole lesion. Fanning क्या कर रहे हैं आप? Fanning basically आप क्या कर रहे हैं? जब आप lesion के अंदर पहुंच गए, तो आप इस needle tip को एक बार ले गए, 2 and 4 movements की, फिर आपने इसका position adjust कर दी. आप पूरा lesion के बाहर नहीं आए. You haven't come out the lesion. You are just adjusting the site. So you have something like this. Yeah, something like this. Okay. So this is fanning. Now there is a single randomized controlled trial done by Shyam Vardharajlu, published way back, I think 2018, उसके आगे पीछे कोई स्टडी नहीं हुई which had shown that the fanning gives you a better yield, which obviously is logical. क्यों? Once you are going to a particular site, you have sampled that, you will have some amount of blood. आप उसी में करते रहेंगे तो टिश्यू नहीं आएगा, ब्लड आएगा. So what is logical? Logical ये है कि आपने एक जगह किया, दूसरी जगह किया, तीसरी जगह किया, चौथा. लीजन ट्यूमर एग्जैक्टली कहाँ है ये भी आपको क्लियर नहीं है. लीजन पूरा है बट सम एरियाज में यील्ड बेटर ट्यूमर टिश्यू. So that's the reason FN fanning has been universally accepted to increase the yield, and this is what everyone does. Retract, secure, disconnect. आपने निकाल दिया और फिर आपने ये मटेरियल बना दिया. So I'll just show you. These are few of our patients. FNA कैसे कर रहे हैं. एओटा है, ये celiac है, large mass in the body of pancreas है ना. फिर आपने सबसे पहले आप डॉपलर लगाएंगे यहाँ पे. You apply Doppler. So this is a very large mass. Young girl, ये अर्चना, I think she's 2015. So there's a mass. You first apply Doppler and then puncture with. At that point of time, I think we had only FNA needle, not FNB. Otherwise, as of today, I would have done an FNB. ये needle जा रही है. एक pass आपने किया. Yes, then you have to take multiple passes. Same another patient again. So this is near to the probe, imaging from D1, CBD, portal vein, large mass. Portal vein looks to be involved here. Again, a young female. This turned out to be tuberculosis. Again, 2013. So this is the pancreatic duct. This is imaging you are doing from the D1. So this is how you sample this. From one part again, you are not able to see good fanning in both of these videos. Okay. So this is what we got. This was an NET and this was tuberculosis, granuloma. So I think I can go on. I have a lot of slides, but I think we will go to the live cases. Is that okay? Or should I continue with this? So now I think technical part I have highlighted. FNB, FNA. So just to tell you that now FNB will be the norm. That I will tell you. Why? Because FNB one gives you better tissue. Gives you tissue, not cells. Number of passes can be reduced. You do not need an on-site pathologist. So you can go away with. You may not need to do the rapid onset examination that is known as ROS. You may not require to do it. Now what is done is MOS, that is macroscopic onset evaluation. So these are the few reasons why. So with FNA, you can't do an immunohistochemistry, which you can do with an FNB needle. So there are all reasons why FNB would be the norm with time. Only problem right now is FNB is slightly costlier compared to an FNA needle. Moreover, we are using the 19 gauge FNB for liver biopsy, which we will show today, and that's obviously slightly more costly compared to a 22 gauge FNB needle. Okay, so these are various needle designs and needle material. So just a word about size. Which size? So what I'll tell you that uniformly we are using for an FNA 22 gauge FNA, except for transduodenal puncture, where 25 gauge may be easier to use. Is that clear? Otherwise, for all practical reasons, 22 gauge FNA needle is the one that is used. Transduodenal 25 gauge may be preferred because of ease of use. That is the only reason why you want to do a 25 gauge needle. Okay. So just I'll put up the concluding slides here. Okay. So EUS guided tissue acquisition is preferred over percutaneous. Why? Because percutaneous leads to needle tract seeding. Now there is a systematic review and a meta-analysis of EUS alone, which shows that the incidence with EUS is very low. a single retrospective study which shows a difference of 4% versus 15% in percutaneous for pancreatic FNA. EUS guided tissue acquisition is best performed with the 22G Francine or fork tip FNB needles using fanning techniques. I've not touched much upon the FNB needles, but the Francine and the fork tip are the needles which should be preferred. This is not based on any company suggestion, but this is based upon randomized controlled trials which tell you that the Francine and the fork tip needle are better than the other needles. That's the reason I put this up. Use of ROSE further increases diagnostic adequacy to 95% in FNA. MOSE is as good. MOSE is macroscopic on-site evaluation is as good as ROSE when FNB needles are used. So you save upon the cost of the pathologist. Mass in chronic pancreatitis, FNB should be preferred. Elastography that we discussed would be preferred, and ROSE may be helpful in this scenario. Again, in uncinate mass lesion, as I mentioned, when you're doing a transduodenal puncture, 25 gauge needle may be preferred. Okay,